Thank you ever so much, Martin. And yes, good morning, everybody. So Sue Harris, Director of Strategy and Partnerships at Herefordshire and Worcestershire Health and Care Trust. I do know a large number of you around the screen. And yes, I'm being joined today by some colleagues. You'll see that that's David Thomas, who's actually going to walk us through the presentation. And he's the Deputy Associate Director of Primary Care and Community Services for Adult Mental Health. And Dawn Stallard, who's really got the finger on the pulse with the detail because she's actually the service manager over the Healthy Mind service. We've also been joined by Jenny Dalloway, who is the lead commissioner at the CCG for mental health services. So hopefully between us, we'll be able to provide more of the detail and answer any queries you may have. Just by way of a bit of an intro, I've worked in mental health services now over 25 years, and we have seen a significant increase in the range of services available, but we still always put them under one banner, and quite reflective that we don't do that in physical health. We talk about diabetes and stroke and cancer. And I really therefore welcome the opportunity today to be able to disaggregate some of what we provide and really do a more detailed update on one specific service. So this is the Improving Access to Psychological Therapies service. And what David's going to cover is really what's within that service. It's quite a comprehensive offer, looking at it as an average or as one total service, often therefore means it's quite complicated to understand what's going on. So yes, thank you for giving us the chance to unpack some of that. Also, who's it for? It's one of the services that people can self-refer. And I think increasingly now, when we've talked about the impact of COVID, that becomes really, really important going forward. Martin's outlined some of the challenges. They remain, and there are no quick fixes to some of those around the workforce. It's a national issue. And likewise, the demand, I think they talk about the mental health pandemic started around 6 months ago and is set to continue for some time. And we don't really know what that will look like. Most importantly for yourself, though, some assurance on the actions we're taking as a trust, what we're doing at the system level, and I think to pick up some of the specifics around the concerns you might have raised earlier, Martin, around triage, and then some of the work we're doing around recruitment in particular. So, David, I'm going to hand over to you to walk us through the slides.
Thanks, Sue, and good morning, everyone. Can everyone hear me okay? Great. Okay. So yes, as Sue says, I've been invited to walk through the slides, which are intended to give that overview of the IAP service specifically. And I wanted to start by saying a little bit about the service itself and its model by way of introduction. I'm conscious not everybody may be that well acquainted with IAP. So IAP, which is to say, Improving Access to Psychological Therapies, is a model that's been around for a little over a decade. It was introduced nationally and at the time transformed really the treatment of adult anxiety disorders and depression across England. It's widely recognised as being a most ambitious single programme of talking therapies. It's also quite a tightly prescribed service. So it works to a very clear service description, the famous IAPT manual, which is about a 150-page document, which very clearly sets out, what we are expected to achieve, and the KPIs, the key performance indicators, kind of, sit around that and monitor performance around that very prescribed model. In the past year alone, more than 1 million people have accessed IAP services nationally to assist with their depression, their anxiety, help better manage their mental health. That's a lot of volume nationally, and we will come to that at a more localized level in a minute, I think. In Herefordshire and Worcestershire, just I suppose a branding point really, IAP services are delivered under the banner of Healthy Minds, and that was a merged service with effect from about 2 years ago, April 2020, when Herefordshire and Worcestershire IAP services came under that one banner, and to a significant extent we do manage them as one service. Dawn, the service manager here today, sits across both counties. I think it's important to say that too. Next slide, please. Just a little bit about kind of entry criteria or access criteria and the overall sort of service description. In Worcestershire, the service supports people aged 16 and over experiencing difficulties such as stress, anxiety, low mood, and depression. The only requirement to access treatment, the only requirements are that service users should be aged 16 or over and that they be registered with a GP in the county. We also actively encourage self-referral via an online self-referral form. And again, this is going to speak to the volume point. And Sue, I think, already touched on self-referral as a kind of a mode of access. Once you refer yourself to the service or are referred to the service, it's a service that provides a range of means of support: online therapy, face-to-face therapy, online face-to-face groups, a range of courses, some very traditional sort of one-to-one type counselling support, but also a range of guided online materials. It's really quite a broad offer, and part of the job of the service is to figure out what is the best fit for each individual patient. We touched on the question of triage or assessment. It's probably worth saying within that, and again, this speaks to the overall question of waiting and the volumes of people going through the service. Sometimes it can take more than one go, if you like, for a patient to find their right pathway within Healthy Mind. So somebody may start out on a course of treatment, and actually between the patient and the therapist, within a short space of time, it may become clear that actually something else is more suitable. So it's not as simple within the service as somebody comes in the front door, they move along a very clear sort of pipeline, and then they go out the back door. There's a lot of stuff going on behind the scenes, potentially as well. We can also, it's worth saying finally, do some important sort of signposting and joining up activity. So we talked about things like wider, I heard on the tail end of the previous conversation, points around sort of wider well-being questions, and those sorts of joining up conversations, signposting and linking patients to other resources are also an important function. Next slide, please. So the self-referral point, just before I talk about waiting, I did mention it's an important one. This is a high volume service. So Healthy Minds as a whole is on course for close to 18,000 referrals by year end, by end of March, for the year. As can be seen from the waiting data, and this is the same waiting data that was provided in alongside the correspondence, alongside the letter from Sarah Dugan, we definitely are experiencing issues with the duration of some waits. There are some significant challenges in some aspects of the service, but I think it's also important to say that the volume of waiting needs to be viewed with the overall volume of activity in mind. So when you look at those numbers, as I say, just have in the back of your mind 18,000 referrals or so by year end. I think that's an important context to those numbers. In terms of that snapshot of total waiting for Worcestershire, that was taken as at, I think, the 16th of March, so about a week ago. Clearly, there are some long waits there, but it's also quite a wide distribution, and this was a point that was picked up in Sarah's response. Whilst there are long waits, a substantial number of patients don't face that level of delay. In fact, a majority of Worcestershire patients are currently embarking on a specific treatment pathway in 4 months or less, which is still longer than we would like, certainly, but it's perhaps not as long as might be inferred from some of the longer waits. If we can turn to the key performance indicators, next slide, please. The service does continue to meet or come close to meeting some of the key performance indicators around waiting. So the national expectation that 75% of patients are discharged from the service should have received their first treatment within 6 weeks and 95% within 18 weeks. And over the last 6 months, one of the other key waiting KPIs is the 90 days KPI, which is that patients should have received their second treatment within 90 days. Over the last 6 months, an average of almost half, I think around 46 or 47% of patients received their second treatment session within the desired 90 days. I will just pick up on that triage question, which was kind of mooted at the beginning. The IAP model is a slightly interesting one in that effectively the access and the first treatment happen at the same interaction. So when somebody is brought into the service, they have a first access appointment with a suitably qualified clinician. At that first appointment, they will also experience, they will have their first experience of treatment too. That treatment picture will then develop. But when we look at those KPIs around 6 weeks and 18 weeks, those are looking at access and triage as well as treatment. That's also why we have that balancing measure of the second treatment within 90 days. It discourages the service from then just accessing people and then just letting them languish, which a less sort of nuanced set of KPIs might encourage in certain quarters. So I don't know whether I've explained that clearly. I just wanted to respond to that question. Maybe we might need to pick it up again at the end, but it felt like an important point to make. I think the other thing I just want to draw attention to within KPIs is really a point, not so much specifically about timeliness, but more about quality of service, although I understand the two are closely interlinked. I've already said that our performance and the way we do deliver the model of the service is tightly prescribed by the manual. The bottom KPI on that table is the recovery target, which is 50%. That's a very clear evidence-based, evidence-led target that 50% of patients, and not significantly more than 50%, but 50% of patients going through the service should be recovering. And there's a very clearly defined and scored way of defining or determining what recovery looks like in this context. And Healthy Minds has been focused particularly closely on maintaining this indicator in recent months, with the intention of ensuring that those who experience treatment through the service have a clinically appropriate and positive experience, which is something I'll also return to in a later slide. Next slide, please. So notwithstanding this, it's clearly the case that some waits are too long, and so this slide lists some of the key actions that we're currently taking to address some of those aspects of service delivery. And again, I know that Sarah's correspondence outlined some of these actions and indeed some others as well. I just wanted to highlight some. So core clinical workforce expansion. We've just finalized bids to secure a further 34 clinical staff in the next training round through the Health Education in England pipeline. Some of those are replacing vacancies, either existing vacancies or vacancies we anticipate in the future as a result of churn, but a substantial number of those are also entirely new posts, which reflect further planned investment in the service over the next 2 financial years. Over and above that kind of injection of new capacity, we're also looking to unlock untapped capacity in the form of evening and weekend working, exploiting an appetite amongst the workforce, some parts of the workforce for additional hours, but also potentially other areas of capacity like additional sort of bank working, that sort of thing. I think the benefit of that is that it will broaden our offer as well. So it will create opportunities for people who perhaps are living their lives to a slightly different rhythm, looking for an appointment at 8 o'clock in the evening, or I don't know, 8 o'clock on a Sunday morning. We can perhaps grow some of those opportunities at the same time. So delivering more volume, but also delivering it in a way that perhaps meets a broader range of lifestyles. We are introducing a triage gatekeeper type role to look at that self-referral model and to help us to manage some of that volume and some of those challenges better. We are also reprofiling the workforce and how we allocate that work. So we have recently removed all of the high intensity therapists from any of their assessment and triage duties, which they were previously doing, and steering them much more towards, focusing them much more towards the longer waiting treatments, which is actually where their focus should be. Balancing that then, we are increasing the number of assessment slots for the step 2 low intensity psychological wellbeing practitioner staff. And we're also putting in increased leadership capacity, some senior PWPs, psychological wellbeing practitioners, to ensure oversight of that, to make sure that we're optimizing that, getting the most efficiency out of it. And Dawn can certainly speak to that point if anybody wants to hear more about that, because she's a great enthusiast for it. Full assessment and treatment waiting list validation exercise is something we're currently doing a deep dive with assistance from our Associate Director of Performance and Informatics and her team, because particularly with some of those longest waits, I think frankly there are some data questions there, as well as there are sort of human and patient experience questions. I don't think we have complete assurance that in all cases we don't have, that we don't possibly have people who aren't really waiting at all, but somewhere the system is telling us that they still are, if that makes sense. So we need to validate and do some more work around that to see what that yields. And then finally, we're working with partners through the Emerging Mental Health Collaborative to look at alternate provision alongside IAPT. So I've talked about vacancies within the service. The thought is, and the intention is, that actually where there is money that we can't spend within the service because we can't get the staff or whatever it might be in the near term, actually can we utilize that underspend elsewhere? Can that be spent on similar services or complementary services in the near term to create more volume and more opportunities for people's needs to be met? So finally, because I've talked for quite a while now, as a counterbalance to some of the lists and numbers, I've just included some. It's not quantitative, but it's the most recent qualitative feedback that we had. I literally just reached and got the February friends and family feedback for the service for Worcestershire teams, and that's the totality of it. You can see on that slide we had whatever there is 5 or 6 bits of friends and family feedback from the service. Uniformly, I think you'll agree, very good, very positive. It seemed to me to be a useful insight into current patient experience, and hopefully does offer at least some reassurance that there are positive experiences being had of this service, even if there are also some challenging waiting time issues. I think that's my last slide, except for so just questions really.
Thank you very much, David. I could see. Does anyone from the board have any questions? Chris, you did put something in the chat, Chris Byrne.
Yes, I did. Yeah. Thank you for that. Yeah. So from what I've understood, it sounds like one of the biggest blocks is obviously getting into the service in the first place. Once you get them, it sounds like you grab them and you triage them. Or perhaps you could just say a bit more about how you deal with people making inquiries right at the start, how you manage those people.
Yes, certainly.
Yeah, Dawn, do you want to speak to that?
Yes, certainly. Obviously, we've got the website that people can self-refer on, or we've got a free telephone number that people can self-refer into. So they will then receive a phone call asking them when they can have an appointment to have a triage with their staff, and that's when they'll be screened by what we call PWP. And once that assessment took place, that is when it's decided which is the most suitable treatment. And as you can see from the waiting list, dependent on which modality, Obviously, it's dependent on how long they'll be waiting, but we are actually trying to encourage people to join groups, because if they did that, or Silverclay, which is interactive therapy online, if they did that, they could do that whilst they wait. So that's something that we need to promote more of, really.
Yeah, thank you. So I kind of wonder if you miss people that way, because if you know, I mean, I could understand the pressures here. I mean, you know, and you obviously want to do something with them, but there seems to be a lot of people out there not getting into one-to-one interventions or discussions early on. It's a capacity thing, and I kind of wonder. And the other part of my question was around the numbers of practitioners able to offer IAP services. There seems to be a lot of vacancies. I mean, what can be done about that? Because that seems that would unlock a lot more people being able to go through the system.
Currently, I think we've got a healthy workforce. And, you know, as I say, we've had some sickness through COVID, but we've got nobody on long-term sickness. And in comparison to other mental health services, we haven't got many vacancies, and we do get those filled. Apart from when it comes to counselling, specialities such as DIT and IPT, which you see that's our biggest weight. So we're really concentrating on that at the moment. We've got a lot of training opportunities out there. We're going around universities also, because it is a fantastic career. And what I can say, you know, we've got a really healthy staff that are really motivated and dedicated to their work. And as you can see, the feedback we get is absolutely, you know, it really does lift their spirits. And all I can say is we do get complaints, and that is mainly about the waiting list. But once they're on the waiting list, we do involve people. We keep them in touch, send them letters to explain that, you know, we have got alternatives while they wait, such as Silverclay, and also the groups, which, to be honest, once they sign up to them, it's a really good outcome also.
Yeah, okay, thank you for that understanding. I mean, I do appreciate the pressures. It's just that, you know, it's important just to not forget them. Thank you.
Thank you.
Simon, did you want to put your hand up?
Yeah, David, thank you for the presentation. And actually, I was going to ask a question about how you manage the waiting lists, the inevitable waiting list, which I think Dawn's just touched on, right? But how we deal, I mean, one of my questions is, well, how do we deal? Because we get a lot of people come to us to complain about the waiting list. And you obviously get people complaining as well. Obviously, there's a lot of work going on. How do we actually deal with this issue and try and deal with this perception that we feel is coming to us? And the second part of my question was going to be about, you know, we know in physical health, locum workforce plays a massive role in delivering physical health services. To what extent are you as a trust using, you talked about using the voluntary sector to, you know, while you've got the money that you can't spend on your own workforce, to what extent is there any opportunity to use locum workforce to help fill the gap while you're trying to recruit and what have you? Thanks.
We are actually utilising bank staff already, but there's not many on the books for IAP compliant workers, which is a difficulty. There is agencies that we could tap into, but what we want to do is concentrate on quality. In other IAP services, what they've done is they've reduced the amount of treatments they give so they can get through the waiting list. And that's something we don't want to do because, as I say, our recovery rate is the most paramount for us. We want to make sure that we keep that quality in the service. So if you do get anybody obviously complaining about waiting lists, please direct them to the PALS team, because we will contact them directly and explain the situation. And that point as well, we can encourage them then to, to probably go for Silverclay or interact with our group work on offer.
Thanks, Dawn. I can see Sue wants to come in, and if Simon, if it's okay, there's also a little bit I'd like to say in response to that. But Sue, do you want to?
No, mine was going to be specifically around the workforce piece, Simon. I think just worth noting, yes, there are vacancies, but the bigger challenge is what I put in the chat. This is an expanding service, quite rightly, and I think we all recognise we need it. but nationally the training places haven't kept pace with what's required in terms of that expansion. So you have a shortfall, and that's true across the country. So that's why we've talked very much about what could that look like over the 2-year period, which is the kind of average time it takes for the people to be trained. And there aren't many shortcuts to that training programme. They have to be ticked for that particular training course to be able to deliver IAPT. And that's what the manual that David talks about outlines. So Jenny, from a commissioning perspective, has been working with primary care network colleagues and the voluntary sector to look at what could we do to meet some of that need, but differently. And that would move us away from being completely compliant with the IAPT targets. But I think we have to recognise that that is preferable to us sitting with slippage, and money that we've got for the residents of Worcestershire with need, and therefore we need to bridge that gap in the short term. So Jenny, I didn't know if you wanted to just quickly talk a little bit about how quickly we're going to mobilise that to try and get some additional capacity in, which won't necessarily be IAP compliant, but will meet local need while the pipeline for the workforce builds back up.
Yes, thank you. Comment on that, just to provide assurance that these are conversations between the clinical directors of our primary care networks and the CCG clinical leads. So we have to understand that actually what we want to do is put some alternate service provision in over the 2-year period while the clinical workforce is trained. We have to be clear on whether that's going to be a clinical therapeutic intervention or alternative support that may well meet people's needs. So our clinicians are working on what they're calling a framework, but basically it's options that can be provided that have to be, again, we need to make sure they're evidence-based. So we're clear that people will have positive outcomes from that intervention. And the intention is over the next month that will be taken through our new mental health collaborative arrangements to get approval and agreement, and then mobilise quite quickly. We've already agreed that some of that delivery, so the commissioning will be at local level, so our primary care networks will lead on some of that commissioning in a similar way as they have over the winter period for us. So we provided some additional funding for each of our primary care networks so they could commission directly, and I think in many cases they've commissioned from voluntary sector colleagues as well. So we're going to use that learning, but it's just being clear, I think, that this isn't going to be clinically trained or clinicians who are trained to deliver IAPT interventions. It's an alternative that we know will meet people's needs from one, which is why our clinical colleagues are supporting that decision and making a recommendation for us.
Thanks very much, Jenny. Lee, did you have a question?
Yes, I was just going to say, as a positive, we are one of those organisations in Redditch that is working in partnership to alleviate some of the waiting lists. We've been in contact with the district partnership, and obviously that's something we're involved in, and hopefully will make a big difference, in the short period going forward. But what I wanted to, and I don't want to keep going over the waiting list because we all know that they are there, and a lot of clients that use us are over 12 months, and obviously they are being referred to us as well. So that's, I'm not going to sort of go there. But what I was going to say is, obviously David was saying there about the triage is very, on the first appointment. The feedback that we get from those same clients, obviously whether they're either directly sent to us or through to you and then to us, come back to say that they feel that they wait such a long time and then get to have that assessment. So that doesn't tally up unless they've got it wrong in the sense that their circumstances changed by that 90 days or whatever you've mentioned. But a lot of those clients felt that they were then told that they weren't appropriate for the service and were just left, and obviously then had to go back into the voluntary sector or go back through the GPs. And I feel that irritated them a lot more than the waiting lists. I think if they'd known that a lot earlier on in the journey, they could have sought alternative therapy or support. And I feel that it grieved a lot of them that they've waited that long to then be told they weren't appropriate, and they weren't necessarily put into another service in the IAP team. They were just told that they were not appropriate for that service. So I just thought I'd just sort of give that feedback. Obviously there's some positive, but I do want, but I will say the things that I've just saw you put down about, you know, plans in place, I agree that those will make a difference. But I just wanted to make sure that that was very clear, because it hasn't been very positive in Redditch at all, and I didn't want that one patient experience there to say how quick it was and great, because it's not been very good here for waiting lists. But you know, hopefully going forward, I agree the things you put in place look well.
Thank you, Lee. Does anybody, Sue, who do you think is the best person, if anybody wants to respond to that?
Dawn, would it be useful to just describe that experience of potentially waiting and then not being deemed appropriate, and how that might be improved upon? It obviously that's the key area of feedback I've just picked up from Lee's comment there, which feels very important.
Yes, certainly. Obviously, what we have sometimes on the waiting list, we have people on the waiting list that are already open to secondary services, such as eating disorders or early intervention, for example. And obviously that would then, is quite clear in the IAP guidelines, is that we are a primary care service. So at that point, because if they're already open to someone, that's just one example. Obviously, I can't think of any other reason other than their needs are too complex. And normally, if that happens, we would refer on in the pathway. We shouldn't and wouldn't leave anybody sort of out there. So, and obviously we'd encourage them to go to PAL so we could investigate that further. So I'm sorry about that experience, but please, you know, bring these people forward, because, you know, we're here to listen.
Okay, Lee?
Thank you.
Yeah, Jonathan.
Thank you. Can you hear me okay? I've had a few problems with my new earbuds. Okay, just give me a thumbs up.
That's fine.
Thank you. Thank you. So we've covered a lot of ground and information today. And I just wanted to play back so I think I understand. So one of the issues that you're facing is capacity of the IAPT service, principally demand versus capacity of practitioners, I think you might call them, and referred to in Sarah Dugan's reply to Healthwatch's letter, and indeed in David's plan slide at bullet 7, this requirement to commission something other than what you've got, what you can't put in place at the moment, normally perhaps through the voluntary sector. So you are looking to put in place an alternative set of services, possibly through the voluntary sector, in order to alleviate some of the demand and give people access to an alternative. That is my understanding. Is that right?
Yes, that's correct. That was what Jenny was talking about this framework of evidence-based interventions that could meet need, but won't necessarily, will not be IAP compliant in the manual sense. But yes, absolutely,
Yeah.
Jonathan.
Yeah, thank you. But, okay.
Practical.
Got it. And I have at one stage, sadly enough, read the IAP manual, and it was quite hard going. So my question is, when is the decision going to take place, and when is this going to happen? So and the reason why I ask is, when I read the mental health strategy that was written and supported by the Health and Wellbeing Board a couple of weeks ago, the wiring diagram at the back, which expressed where the mental health partnership sits, I couldn't understand where decision-making power and authority lies. So who is responsible for saying, do it? Who is responsible?
I can respond to
say,
that, Jonathan.
Press the button and make it happen.
So in terms of the decision making, we have an executive group within the new arrangements, which is a partner, and that is where the decision will be made. Our intentions are, we're hoping we have hoping that, in which case we can approve that, and then from there on we can mobilise. And as you're aware, in the meeting are aware, if that's a provision through the voluntary, and that was our experience over the winter period, Lee has reflected that she doing, they were able to mobilise quite quickly to support the local area. So certainly over the next period, 3 months or so, we'd expect to be able to see an alternative offer being made available.
Okay. Thank you, Jenny. Can I hold you to 3 months then? So that's end of June.
You can.
Thank you, because it's important, and I have a declare interest here because I have a counsellor who's accredited that has been with us a long time. I've got evidence, anecdotal and otherwise, of his value. I keep asking people like the National Lottery to fund him, which frankly seems ridiculous when I'm running charity for some of the most socially, economically disadvantaged people in the county. You've got the money, I've got the person. This couldn't be that difficult, I hope. So let's hope that at the end of June we can arrange this so it works. I accept in the short term, but please let's not let perfect get in the way of good enough for government work, please.
Thank you, Jonathan. Sue, you have actually put something in the chat. Would you like to, just in case people have missed it?
I just think, Jenny, you went a bit glitchy. I don't know if that was just my experience. So I just didn't want people to lose some of the time frame we're working to here. So yes, this is the next sort of meeting of the mental health executive, and we obviously need to run all of this so it can be formally signed off by the people who have the money, which it will still be the CCG. But we did a really good job at turning around that winter monies that came into the NHS quickly. We were quite pragmatic. So I think it's just making sure we're clear about the clinical outcomes, the evidence base is there. It bolts into those clinical conversations at the PCN level. And the fact that we've got the learning over last winter, I think it just means that we will be able to move with this in months instead of what often feels like a very protracted process for the NHS in terms of actually addressing some of the issues we're talking about here.
Thanks, Sue. Does anybody else from the board have any questions? Because I have a couple of questions from members of the public. Simon, did you? You had your hand up at one point, but I think you took it down.
I did, but I took it down because the question got answered along the way.
Thank you. So I've got 3 members of the public with questions. So I've got Gaynor. Oh, you're still mute, Gaynor.
Oh, thank you. Yeah, so I got 3 questions, but how many weeks of treatment of counselling and CBT do people normally get? And you, David mentioned that people are classed as recovered. How do you determine recovered, and what's the time span on people being recovered? And from my experience of the support groups we run, first of all, yes, the waiting times and people getting frustrated with that. People don't like being offered the groups. They want the one-to-ones. But also that because they get a phone call from a private number, some people don't like answering the private number calls. And because of their mental health, they could be in bed, but some of them could be in work and can't answer the calls. And so for whatever reasons, and that's just a few of them, some phone calls are not answered. So then they get a letter then following that to say that they're off the service and they've got to go and start again. And I've seen these letters as well. So, you know, what can we do about that? Because surely there should be, say, like a letter sent out to say a certain time, and if you can't make that time, can you contact us, and something along those lines?
Gaynor, the first contact we will have is that we normally send a letter out, and then that letter gets asking them to get in touch with us to make an appointment. If they don't respond, we phone them, and we keep trying to phone them. And then once that's put in process, it's booked in with a therapist. But obviously, we've got to be strict on our DNA policy. We will try, and if the person's not answered, we'll give them a second chance. But if we have 2 cancellations, we have to go along with the DNA in view of our waiting list. I do hear you about the withheld number. We've got staff now put on, so we've got a system, so it's not a withheld number anymore. So it comes up with the Alfie Mine number. So that is helping, because we did take that on board, the fact that withheld number, obviously people think that it's going to be a cold call. So that's also being addressed as well. But as you can appreciate, you know, if you got a GP appointment, you know, you turn up, don't you? And it's quite frustrating sometimes where a therapist, for example, you know, I can give you quite a lot of examples of people on their driving lessons, you know, and say, I can't talk now, but they've actually agreed to that appointment, you know. So we do give them a second chance, but we can't really keep that open any further than that. And it does get frustrating, but if people do get in touch with us and give us a genuine reason, we will book them back, and we won't put them back to the beginning again. We'll take them from the date of their original referral.
Thanks, Dawn. Sue?
I just asked Dawn to pick up on the average CBT duration, and then David, I think there was a question from Gaynor about recovery, sort of definition, and sort of what, you know, what sort of time frame we're measuring that in.
Sue, I think Dawn can probably speak to that as well. Dawn, is that okay?
Yeah, certainly. So it's we generic counselling is six sessions, but we're trying to make that more specialist now. So it's more specialist. We'll go to 12 sessions to 16, and throughout the sessions at the end, they will do a questionnaire to see where they are. And by the time, obviously, we get into the around 10 sessions, we have an idea on recovery. If we feel that we need to give the patient additional sessions to enable recovery, then that will be put in place. But you know, we do aim between 12 and 16 sessions, but it can go up to 18, and some points as well 20.
Thanks, Dawn. Is that okay, Gaynor?
Yeah, that's the experience has been that 6 sessions, and as an example, some of hours have said by the time you start getting into it of opening up, then the 6 sessions has ended, and then it's stopped because they said, well, you've had your 6 and that's it. So yeah, so in theory then it sounds like they should carry on to more, but in practice, from what people are telling me, it's not happening.
We normally,
thank you.
Yeah, when it comes to general counselling, we are looking to put them into either CBT if they fit that, you know, if it feels that it's going to be the right therapy for them. So if you have counselling and you haven't recovered by session 6, you can be put forward to another modality. So we don't just discharge if there's been no recovery. We can, you know, forward them to another. But obviously, the only problem there is sometimes they may have to wait, you know, for a more specialist service. But most patients are happy to do that.
Thanks, Dawn.
Yeah. It's the point is, it was as soon as they start coming up to the 6th session, at the point of opening up a bit more.
Yeah.
And then they get told, right, well, yeah, we got 1 more week, or, you know, something like that, and your 6 sessions are up, right? Yeah. Right. Or you've got to wait for the next one, or whatever.
Yeah. Again, Dave,
okay.
Should I just say, David's just put something in the chat. If you can encounter it again, if you could encourage the person to contact PALS, and they can have a look at it.
Yeah, okay, thank you.
Thank you. Brendan.
Dana.
Yeah, if you don't mind, I'm going to have sort of 3 questions. The first thing is, what degree of systematic feedback do you get from those people who complete the Healthy Minds program, other than family and friends, which, no disrespect, but at times it has been described as fluffy good feel, and there's nothing wrong with fluffy good feel, but systematic feedback. Secondly, very interested in introduction of triage, and beside it, the mention of gatekeeping. Sadly, for people trying to access services, a gatekeeping mentality doesn't necessarily provide a welcoming environment for people making initial contact with the service. And to my mind, it's actually quite an important aspect of people who are in a degree of anxiety or depression, that they're, dare I say, welcomed with compassion into any service. And just extending that, I wonder to what extent the triage will provide expectation that's realistic to the individual accessing for the first time in terms of potential waiting, etc. I'm sorry I'm throwing these at you. And also, to what extent is escalation taking place? Because I hear of people who have made contact with Healthy Minds, and I'm sorry, this is a value judgment from me, not in a million years is Healthy Minds appropriate to them. They should be, they should be into another service. And finally, going on the compassionate bit, is that when people have been waiting for a period of time, one of the feedbacks that I get, and I felt it many years ago myself, way before I act, was that when you're waiting for something to happen and it doesn't actually happen, you can feel abandoned by the mental health system. And I take your point, Sue, on mental health system. You can feel abandoned. And wouldn't it be a nice thing if there was some kind of follow-up communication? I don't even mean necessarily a phone call, but even a simple letter that says something like, we appreciate you've made contact. The waiting times are still, you're still in a waiting list, and you are important to us. And if anything's escalated, perhaps please see your GP or whoever it might be. Now, I've thrown so much at you, but gatekeeping, feedback, maybe more quantitative stuff, the kind of stuff that I would tend to look for, and the managing expectations, and just following up saying we appreciate your waiting, and you are important to us.
Brendan, you've raised some really good points there. In Hereford, they already got a system where they write to the patients every 8 weeks, and that's something Worcester's got to follow, and we are looking into that. But at the moment, we have got people on the waiting list that we know exactly what you said earlier, they're too complex for us. So that's something else we're doing. We're going through the waiting list as we speak, because some people are open up to 2 services, which we need to address. And regarding the triage, what we've got, it's not going to affect how we're doing our assessments. So if we have an assessment, for example, that the needs are too complex, rather than that person having to deal with, referring on to other services, they can pass that on then to what we're going to call a duty worker. That duty worker will keep that person and make sure they stay with that person until they're on the correct pathway. So then they can tell the patient exactly what waiting list they're on. And meanwhile, what we're doing as Worcestershire, we are going to contact everybody on the waiting list to apologise And just because we may then as well, people may contact us and say, we no longer need your service, for example, which will help. Because as you know, when people first come to contact with us, they are in a crisis, and sometimes that crisis can diminish. So we're open that will also help as well. Yeah. So we are looking at every avenue. So thank you for your suggestions. It's really appreciated.
Thank you.
Thanks, Brendan. Sue Pritchard.
Much. Can I, so I work alongside Tanya in the public health department, supporting mental health and suicide prevention. We have, over the last 6 months, alongside the CCG, commissioned an online mental health support system called Quell. And we're really keen to promote this to anybody who has a mental health issue that is on any waiting list for mental health support. And we're trying to promote it through primary care, through mental health practitioners. It's free of charge. There's no waiting list. They've got capacity. So we really want to try and encourage as many practitioners to suggest that as an interim measure while they're waiting on the list. So if I don't know what I can do, we're trying to get the information out through the Health and Social Care Trust and through primary care. So it's really just to say, you know, please use that service because they've got capacity and they've got professionals there who might be able to provide some interim support and reduce some of those waiting lists. So, you know, I'm happy to pass on the information to you, Dawn, directly, in the hope that we can use that service is available in Herefordshire and Worcestershire.
I have ensured that that's put on their website, but now you said that, so perhaps we could put that on our letters as well that are sent out. That would really promote you as well. So yeah,
that's what I was thinking. Yeah.
David, did you want to add something?
Yeah, I just Dawn's touched on it already. We are very aware of Quell, Sue, and we've had a number of conversations about it. There is a slight tension in that, you know, I'll go back to the IAPT manual and the crucial thing about the service being compliant with the manual. Quell is not, you know, does not align with that. So how we interface with Quell, we just need to be careful. We're not kind of bringing it into the fold, as it were. So I think when we're looking at things like correspondence, we'll just need to have that in our heads. But strongly endorse the principle of it's another tool and another resource and another opportunity for people to get their needs met.
Thank you. Lee.
Okay, I was going to sort of discuss again. I know again is saying not long ago that some service users don't like group work and want one-to-ones, and again listening to Dawn etc. about their groups that they've got. I think that is something we all maybe need to sort of collectively work together, because we may be VCS, but we, even with nearly 40 practitioners here at Sandycroft, I'm still inundated with waiting lists and people coming through, and the best way to deal with that is group work, and we do have group work. And it's quite surprising that when you speak, and we do triage here, and we do normally have conversations with them on a regular basis and try to get them on those groups. And I would say it's very hard to get people to engage on it, and they'll go, no. And, you know, we do offer them, and I imagine that's what Healthy Minds do as well. And I don't think that's ever reflected. So this is in defence of Healthy Minds, because we have the same problem here, and they'll not sort of just, you know, share that and make it sound like I've been waiting. And yet the feedback from Sandycroft, which I imagine is exactly the same as Healthy Minds, I would say around about 80% plus people, if they do make that step into group work, actually a high proportion will stay in that group work and find it that it's met their needs. And done there. So I think some work around us all working together to try and make group work more attractive, because I'm a firm believer that it would make a massive difference to all our waiting lists.
Yeah, and I know that Jenny earlier on in the chat was saying that clinically it's very, very effective.
Yeah.
Thank you. Simon, should we make this the final one? Because I think we need to wrap it up, actually. I think it's been a really, really good discussion.
Well, my point's about communication. What seems to have come out this morning is a lot of patients don't know where they are in the system or what service they're actually receiving, which is, you know, not what we find with physical health usually. And I know when we've done a lot of our research in the past, one of the issues that Susie's usually come back to me with is that people just don't understand where they are in the service. Whether, Sue, there is anything that could be done to improve communication. I can understand it's difficult, but whether anything could be done to improve communication with patients so that they do know where they are in the service might be useful. David's going to tell me you already do it and it's just not cutting through.
No, Susie and the comms team and the engagement team in the trust have actually been pulling together a really simplistic overview of the services that you can actually directly access, because a lot of the services do require you to go through your GP if it's a more specialist need. And so there's something about making sure that's clear, because otherwise you put them all on a sheet and you instantly get quite overwhelmed. I put earlier, we're doing a lot of work with general practice, so it's really clear for them as well what's there, who can access what, and make that more accessible. I think your point, Simon, though, is when you're in a service, are you clear which service you're in and therefore what your journey might be? And that is definitely something I will take back and think about in terms of this whole look at accessible communications. I mean, some of what we send out is not the easiest to navigate. So we have got a trust-wide programme really saying, are we, you know, being upfront, for example, about some of the challenges and managing some of that expectation, but also just making it plain English. So that's another area I will take forward. Are we clear enough to people about the service they're actually in and what they can realistically expect going forward, and what some of that journey might look like?
Thanks. I think, David, you had something. Yeah.
I am. Thank you, Chair. I am itching to come in there. So I absolutely endorse Sue's comments. I think there are just quickly a couple of things. So firstly, we have, with the comms team, we've already reworked, I think I can see Dawn nodding, all of the IAPT correspondence templates coming from precisely this point of view, plain English, you know, and they you know, they've gone from in some cases quite, you know, jargon rich documents to much more user friendly, simple, straightforward correspondence templates. The other thing is, I think in terms of when people are in services, as we move forward, the thing that is really going to make a difference here is the total patient experience work, where we really are looking in, you know, trying to look in a really holistic way about, you know, how patients orient themselves and how we keep them apprised of where they are, what's going on for them, and develop that conversation. And that goes back to some of the earlier points about things like Silver Cloud and other things like that, making sure that the spaces in between individual therapeutic interventions, those also get used as well, because that time can get used too. So, you know, waiting doesn't just have to be waiting, it can have a therapeutic value. So I think there's a lot we can do there, and there are definitely irons in the fire.
Thank you very much, David. Simon, is your hand still up, or have you, is it a legacy hand? Anything you wanted to add?
That was the hand from my question that I just asked.
Thank you very much. Any other questions? In which case I would just like to thank Sue and Dawn, David and Jenny for coming along. I think it's been a really, really useful conversation. Thank you very much.
Thank you.
Thanks so much.
Thank you.
Thank you.